Hello, my name is Carolyn Abbott, and this is case study number 88, Iron Deficiency Anemia for Nursing 711 Advanced Physiology and Pathophysiology. JD is a 37-year-old white female who presented to her gynecologist with a 2-month history of bleeding between periods and 6 days of heavy bleeding and cramping during her last two periods. She also complains of weakness, fatigue, and urinary frequency with mild incontinence. Iron deficiency is characterized by the depletion of total body iron, including macrophage and hepatocyte iron stores, reduced levels of circulating iron, and an insufficient amount of iron available for circulation. The World Health Organization recognizes IDA as the most common nutritional deficiency in the world and estimates that approximately 2 billion individuals experience iron deficiency anemia. Those most at risk are women and children, regardless of their socioeconomic status or geography. The most common causes of IDA are menstruation and gastrointestinal bleeding, but it can also be caused by decreased dietary intake and decreased iron absorption. Some inflammatory causes include congestive heart failure, chronic kidney disease, and irritable bowel disease. Global iron deficiency accounts for adverse outcomes of pregnancy for both the mothers and their newborns. Impairment of cognitive abilities in young children, decreased physical capacities in adults, and a cognitive decline in older adults. Total body iron is distributed among hemoglobin, myoglobin, proteins responsible for cellular metabolism and storage, which occurs predominantly in the liver, spleen, and bone marrow. A small amount of the body's total body iron is found in the circulation, bound to transferrin. Transferrin is produced and secreted mainly by the hepatocytes, and its function is to transport ferritin to the erythrocytes in the bone marrow for erythropoiesis. Dietary iron is available in two forms, heme and non-heme. In the heme form, ferrous iron is the type that is present in animal food sources such as meat, poultry, and seafood, and it is much easier to absorb than the non-heme form. The non-heme or ferric iron is the type that is mostly found in plant food. Ferric iron from plant sources is reduced to ferrous iron by the duodenal cytochrome B enzyme, after which it is either stored by ferritin inside the epithelial cells of the intestine, or it is exported into the circulation by ferroportin. Iron hemostasis is controlled by hepcidin. Hepcidin is a protein that is produced predominantly in the liver by hepatocytes and is responsible for the degradation of ferroportin. Ferroportin is found on macrophages and duodenal enterocytes and is a key factor in the recycling of iron from senescent erythrocytes into plasma and the absorption of iron from the gut into circulation. Iron deficiency suppresses hepcidin levels, which in turn causes a decrease in ferroportin degradation. It also causes an increase of transferrin production and decreases the levels of iron-bound transferrin in the plasma, ultimately leading to a reduction in total body iron stores. Causes of iron deficiency anemia include inadequate dietary intake, defective gastrointestinal absorption, loss of iron such as with bleeding or malignancy, and increased requirements such as with pregnancy, infancy, and adolescence. The 3 stages of IDA include depletion of iron storage, iron deficient erythropoiesis, and ultimately iron deficiency anemia. The clinical features of IDA include pallor, weakness, easy fatigability, tachycardia, and breathlessness. The patient may also present with koilonychia or spoon-shaped nails and may also report pica. JD presents with a 2-month history of intermenstrual bleeding, menorrhagia, urinary frequency with mild incontinence, and extreme fatigue and weakness. Her last 2 periods lasted 6 days with heavy bleeding and cramping. Her medical history includes G5P5, with 4 of the pregnancies occurring within the last year. All babies were born healthy via vaginal deliveries, and there were no complications. Patient also has a 3-year history of left knee osteoarthritis, which is most likely due to significant trauma to the knee when she was involved in an MVA at age 9. Due to a progressive increase in the pain in her knee, she recently increased her dose of ibuprofen from 3 tablets a day to 6 tablets a day. On the recommendation of her PCP, she also started taking OTC omeprazole to prevent gastrointestinal bleeding. She is also being treated with a diuretic and a centrally acting antihypertensive drug for a 3-year history of hypertension. Family history. Father, age 66, is alive with angina. Mother, age 62, is alive with arthritis. Brother, age 35, has diabetes mellitus and hyperlipidemia. Sister, age 34, has a history of depression and hypothyroidism. Her 5 children, ages 4 months to 9 years, are all healthy. Social history. Both parents are Greek. She has been a strict vegetarian for the last 5 years. Review of systems: mild urinary urgency with incontinence, mild shortness of breath, progressive irritability with difficulty concentrating. Meds include birth control pills, ibuprofen 200 milligrams 6 times per day as needed, omeprazole 20 milligrams daily, hydrochlorothiazide 30 milligrams, and methyl-dopa 500 milligrams twice a day. Allergies: erythromycin and aspirin cause GI upset. Physical exam. She's tired and pale looking and overweight. She has seborrheic keratosis over her upper back. Sclera are bluish with slightly pale conjunctiva. Her oral mucous membranes are pale but moist. She's tachycardic at a rate of 140, with a systolic murmur heard best at the right sternal border. She is also hypotensive at 100/40. Abdomen is soft and tender to palpation. She has joint enlargement and limited range of motion to her left knee. Labs CBC was significant for an H&H of 9.1 and 27.5, RBCs of 3.3, MCV 71, MCH 19, MCHC of 27. Iron studies were significant for iron of 35, TIBC 706, transference saturation 5%, ferritin of 9.7, and FEP of 54. Her peripheral blood smear showed a significant number of hypochromic and microcytic red blood cells with mild anisocytosis and poikilocytosis. Her pelvic ultrasonography was significant for an irregularly enlarged uterus with 3 submucosal masses measuring 1/2 to 1 inch in diameter, 1 subserous mass measuring 2 inches in diameter, and 1 intramural mass measuring 3/4 inches in diameter. The findings are consistent with uterine fibroids, leiomyomas. The management of iron deficiency involves a 3-step process. First is to diagnose IDA based on the clinical presentation and serum ferritin levels. The next step involves identifying and managing the underlying etiology, and finally, iron repletion. In addition, we are responsible for assessing the patient's oxygenation, fatigue, and activity intolerance, addressing any nutritional deficiency, providing education and support, and monitoring the response to the treatment. As we focus on the qualities of the Lord, it inspires us to provide comprehensive, Christ-centered care to patients suffering from IDA. Continuous spiritual growth is essential for the Christian advanced practice nurse, as it goes hand in hand with our ability to provide Christ-centered care. I will instruct you and teach you in the way you should go. I will counsel you with my loving eye on you. Psalm 32:8. Three case study questions for your consideration include: the patient in this case study has 7 potential contributing factors for the development of iron deficiency anemia. What are they? What is the potential significance that the patient was born to Greek parents? And finally, provide 5 different treatment modalities that will help resolve deficiency anemia in this patient. And the final slide includes the references used for this case study. Thank you.